In an otherwise normal heart, a large atrial septal defect, an ASD, would be considered pathologic and we would close it. But for certain types of heart conditions, an ASD is required for survival, and not having a large ASD leads to bad things happening. For these kids, we make an ASD. So let's talk about balloon atrial septostomy, BAS. The two most common types of heart disease that require a BAS are transposition of the great arteries and single ventricle physiology, for which we'll use hypoplastic left heart syndrome as an example. In transposition, the aorta and main pulmonary artery are coming off the wrong ventricles, causing blue deoxygenated blood to exit the aorta back to the body, and red oxygenated blood to exit the pulmonary artery back to the lungs. For the baby to have a survivable oxygen saturation, blood needs to mix across an open ASD. Lack of an ASD will make the baby very blue, even if there is a PDA or VSD. Here's a baby with a very small ASD and a tiny amount of flow across it. This baby is blue. In hypoplastic left heart syndrome, the left-sided heart structures are very small and not functional. Very little to no blood connects at the left ventricle. If there is no ASD, or it is too small, the blood backs up into the lungs, resulting in severe pulmonary edema and a very blue baby with poor cardiac output. Open the atrial septum and blood can flow across to the right atrium and then to the systemic circulation via the PDA. The immediate treatment for both of these problems is the same, balloon atrial septostomy. The first BAS was performed by Drs. Rashkind and Miller in the mid-1960s for transposition of the great arteries. Previous to this, opening the septum required a thoracotomy. A BAS is palliative, meaning it doesn't fix the heart, but can stabilize the baby before they have a more definitive surgical procedure, such as the atrial switch or the Norwood. The BAS can be done in the ICU with echocardiography, but at my institution we do them in the cardiac catheterization lab with fluoroscopy. A catheter with a deflated balloon is threaded from the femoral vein, through the IVC, into the right atrium, then across the PFO into the left atrium. The IJ is usually avoided as a point of access given the difficulty getting the catheter turned in the right direction to cross the PFO, but it can be done this way. Remember that all babies have a small hole in the atrial septum that is used before birth as part of fetal circulation, and a catheter can usually be threaded across this. The balloon is inflated in the left atrium, and then we pull. Really pull. And pull, and pull, and pull, until finally it pops, and the septum tears. We repeat this a few times, just to be sure it's open. And that's usually it. If this works, the saturations will rise to something more typical of a complete mixing lesion. If the hole is not wide enough, or doesn't stay open, a stent can be placed between the right and left atria to improve flow. While necessary, BASs are not without complications. Anytime you stick something in the heart, there is a risk of inducing arrhythmias, damaging valves, or perforating the heart. The vessel used for access can be damaged, resulting in a cold, blue leg. Stroke was once thought to be a complication of BAS, and you may still hear that, but further research suggests that's not true, as the babies that require a BAS have many risk factors for stroke that are not related to the actual procedure. And if you are taking care of these patients in the ICU, hemodynamic instability after BAS is common, with need for fluid resuscitation and vasopressors. That's not the fault of the BAS, but a side effect of a sick baby undergoing anesthesia with an abnormal heart and a change in loading conditions to that heart. If the baby later undergoes a two-ventricle repair, such as an arterial switch, the hole between the atria can be closed with a patch. If they have single ventricle physiology, that hole is here to stay.